Hello, our friends and our patients from all over the world. Today, we are together with Kiran and Lizan to talk about the developments of on urticaria research, and we just published new guidelines on urticaria. We had a very nice UCARE meeting in India, which was hosted by Kiran, and we learned a lot. And there are a lot of molecules on the way that are being developed for urticaria, being tested for urticaria, and we will see how they will work. So in this UCARE for You webinar, we are planning to learn more about the recent developments in urticaria research, topics from conferences and new treatment options, as well as we want to highlight what kind of difference do these treatments make for our patients? What do they mean for a daily life of our patients? And you see our topics for today. There are 3 15-minute talk. Please provide your questions during we are talking. Then we will check during the discussions what kind of questions you are asking, and we will try to answer your questions. But the question session will be at the end. And at 4, we are planning to finish our webinar. So here, and first, I should introduce myself. I am Emek Koca Türkgöncü. I'm a professor of dermatology, currently working on urticaria. Of course, I have been working with urticaria patients for 20 years, and currently I'm working in Allergology Institute of Charité Berlin. And it's my great pleasure to introduce and welcome Professor Dr. Kiran Godse from India. He is the king of urticaria in India. I would say he has been working on urticaria for so many years. And Lizan Wong from Taiwan is a very enthusiastic doctor. She's a dermatologist having a lot of publications and experience on urticaria. So I want to have a look how many registrars we have. We have 125, but I'm sure it has been more than 125 because it was I think 3 days ago. So I'm sure we have more now. And you see, we are covering all the world, and all the world is watching us. So hi to everyone. We are very happy that you're there. As I mentioned, please leave your questions in the Q box or in the chat. We will try to answer all of them. And please, at the end of the webinar, don't forget to remember, complete this feedback form on how we did and what you would want to hear more in these UCARE for You webinars. You know, UCARE for You is dedicated to patient education. And please subscribe to our newsletters, and then you don't miss any new webinars. So please also follow us on social media and websites. You will have very useful information there. So without further ado, and I also want to, of course, thank our sponsor, Novartis, for their kind support, because it's only possible with their support or other companies' support to provide these information to you. So I'm now stopping sharing, and it's my pleasure to invite Kiran Godse to give his talk, and he will be talking about highlights from the International UCARE Conference. He has hosted very nicely. It was a really wonderful Congress. We learned a lot, and highlights from the Congress and what patients should know. Please, Kiran, come to the stage.
Yeah, thank you, Emek, for that wonderful introduction and this thing. So typically, this is one of the exciting years for urticaria, newer guidelines, newer molecules, and new insights into urticaria, which is going to help all of us and our patients. So this is from the highlights from the International UCARE Conference, what patients should know. So we all know urticaria is a disease which is easy to diagnose but difficult to treat. For patients, remember that urticaria wheals lasting for more than 24 hours. Please think of urticaria vasculitis and show to your physician. Angioedema is the swelling of the lower dermis and subcutaneous. It is more painful. It can take up to 7 to 2 hours. But for all the patients, if you get angioedema without urticaria, you have to rule out hereditary angioedema with the help of a physician. So we all know it's an autoimmune disease with unpredictable course. Each hives and angioedema, around 1 to 1.5% of the people are affected. Working age, it is typically 20 to 40 with women more than men. And up to two-thirds patients experience both angioedema and hives, and only 5% can experience only angioedema, and more than 20% will have symptoms after 5 years. So typically it can go up to 5 to 20 years. So it's a long story. You have to be with your doctor and take the best treatment available, because now you have got a newer and newer treatment available. So again, each Chandri hives urticaria should disappear in 24 hours. Take a mobile photograph and check every 12 hours whether it's disappearing. And angioedema also will take up to 72 hours to disappear. UCARE is a global urticaria network founded in 2012 with more than 50 countries, more than 4 consensus guidelines, and more than 100 expert centers are there all over the world. And typically it is developed, it is UCARE centers are specialized centers which develop evidence-based guidelines, ensures that patient receives standardized high quality care regardless of geography. And our mission is to standardize urticaria diagnosis, treatment globally through evidence, education, and excellence. And our latest guidelines are already on the journal, that is 2026. So we all know the global burden of urticaria. Nearly 1% of the global population has chronic urticaria. 20% is the lifetime risk of acute urticaria, and female to male ratio is 2:1. Remember that urticaria can last on an average 5 to 7 years of duration, and few patients will have up to 20 years, and it is all over the world. It is same with Latin America is little higher than the others, but typically 1% of the population is do suffer from urticaria. So acute urticaria is one which lasts up to 6 weeks and disappears. 80% will resolve in less than 6 weeks. Only 20% can go into chronic urticaria, and chronic urticaria is one which is more than 6 weeks, and what we all are bothered about. Inducible urticaria is a trigger base affecting 15 to 20% of CU cases, and hereditary angioedema is a rare one, but there is a distinct treatment and distinct pathophysiology for the same. So the doctor's key tool is the Urticaria Activity Score, which is available on Cruise app, which is freely downloadable for you, and you can actually assess the activity whether it's mild, moderate, or severe. And a moderate to severe urticaria has significant impairment of quality of life. It is high burden, and patient needs to see a doctor immediately, because these patients are really disturbed with their hives. What happens inside your body is, well, there is step one is there is a trigger, something inside the body or outside, and auto antibody activation, which are either IgE or IgG types, which can actually trigger mast cell, and mast cell degranulate with release of histamine, prostaglandin, leukotrienes. A skin response is vasodilation, leakage, and erythema, flare, wheal, and red patches all over the body. And systemic involvement can occur in the form of deeper layer swelling, fatigue, sleep, and emotional impact. So UCARE treatment ladder has been standard for many years. Now it is being upgraded recently, but you start with the second generation antihistaminics, which are very safe. Patient can take it continuously uh, for a few to several years. If there is no response, a doctor will make it up to 4 times the standard dose. If there is no response, omalizumab can be added. It's an anti-IgE biologics. And then cyclosporine or other immunosuppressant, a specialist or a dermatologist or UCARE centers will try using it. Typically, steroids are not to be used long term. We only use it for the short term steroid to control the flare. So these are the new guidelines recently published. What you can see here, the two new molecules, exciting dupilumab and remibrutinib, both are being licensed now to treat urticaria as a second line therapy. After your 4 times antihistaminics fail, you can always use this treatment, and then other remains virtually same. Well, omalizumab has changed how we treat almost 10 years. 2013 it is being launched. So the evidence knows that almost one third patient get complete response and 50 to 60% patient do get well controlled disease. It is approved for adults and child for more than 12 years. Most of the patient will show rapid response and long term safety is being known, and now we have got omalizumab biosimilars are available which are economical and patient can take it with the help of a UCARE physician or a dermatologist. Well, it's a bad disease because problem is it can come anytime, anywhere to anybody. It can get swelling, especially stress time. At the office time when has to present, you can get. That's why it's a bad disease. Anxiety and depression is almost in half the patients. School impairment, work and sleep disturbances are the more problematic factors, and 30 to 40% patients do suffer from anxiety or depression. And unpredictability of this disease makes it a bad disease. Patients cannot hide urticaria because it can come anytime and anywhere. So that's why complete control is what patient wants, and now we have medicines to give you complete control and treat the disease as long as it is there. So this is a new molecule remibrutinib, which is a BTK inhibitor in the mast cell. A BTK is protein tyrosinase kinase, which can be inhibited by this molecule and cause complete control of hives. It is being already approved in US and Europe, and we are eagerly awaited that all over the world it will be available, and the response is quite impressive. Dupilumab is a new molecule. Just it is being actually approved for 2 years and onward for CSU recently. And again, most of the UAE, Japan, USA, Brazil, it is approved. It is good for those with atopic comorbidities. Typically, it works for antihistaminic resistant CSU, and those with atopic comorbidities, it works better. Angioedema, we all know that you have to, if you got angioedema, go to a physician. You need treatment, either antihistaminic, steroids. Omalizumab can reduce the episode, and sometimes adrenaline is required. So, getting angioedema, you need to go to a doctor immediately to get the treatment. Treatment wise, we investigations are being recommended. Minimum only 4 investigations are recommended for all CBC, CRP, antithyroid antibodies, and IgE. Those who have got specific other diagnoses may go for tryptase, ANA, C3, C4, stool, urine, blood sugar as per the history. But we do not recommend extensive allergy panels, food challenges, or elimination diet without evidence. And for inducible subtypes, we advise provocation test, which a specialized UCARE centers and dermatologists or a urticaria specialist can do. Acute urticaria, we know, which have commonest causes infection, followed by medications, then food and idiopathic. Typically, acute urticaria is little easy to treat. 4 to 6 weeks generally disappears, but maybe 20% patient may go into chronic urticaria. So patient journey is important. When patient gets urticaria, patient keeps on searching for a nearby chemist or some doctor, GP for a visit. He will give some initial antihistaminic prescription, but patient keeps on getting again and again. Then patient need to go to a dermatologist or an allergologist or a UCARE center where a structured diagnosis will be done. A step-up therapy of either antihistaminics and omalizumab can be tried with new molecules, and patient can expect remission or control of the disease, but overall it might take few to several years. So diagnostic delay is a key problem. Anybody getting red hives, you must go to a specialized center for diagnosis and treatment, and most of the treatment is safe and antihistaminics are available easily everywhere, which patient can take till it goes. Triggers: patient must know that NSAIDs and aspirins, painkillers are the worst. They can worsen your urticaria. ACE inhibitors can aggravate angioedema, and gliptins are to be avoided. And sometimes some other medicines also can trigger urticaria. Lifestyle, stress, exercise, alcohol, these are important things. Patient should avoid tight clothing and pressure on skin, and some infections also can trigger urticaria. But not common trigger is food allergy. Food is not the cause of chronic urticaria, so don't have heavy restriction of eating food. All your home food you can have. Routine environmental allergens, routine immunization, routine cosmetic skincare can be continued because they are not the cause of your urticaria, because most of the urticaria is supposed to be autoimmune or autoallergic, and less than 5 to 10% is a true food allergy. Monitoring your disease, again we have a Easy Cruise app available. I will be showing you that, which is available. You can track your urticaria activity score for 7 days. your DLQI, your urticaria control test, and angioedema activity score, which can be added on the cruise app, and you can get the complete understanding how your disease is behaving, and your doctor also find it very useful. So I recommended all those urticaria patients download cruise app, and you can always enter your data and get the how you are showing the response. Special populations, well, pregnancy is one where CSU may worsen in a pregnancy, but remember, urticaria will never harm your child or pregnancy can go smoothly. You need to take antihistaminics, loratadine and cetirizine are safe. Omalizumab, there is limited data, but we do use it for this thing. And typically, we use avoid steroids for urticaria in pregnancy. Pediatric urticaria is again common, acute is more common than the chronic, but we have cetirizine, loratadine available which can be approved, can be given safely. Omalizumab is approved from 12 years and onwards, and generally spontaneous remission is very common. In pediatric patient child, it is in 3 to 4 years the urticaria may disappear. In elderly patients, again, there is a higher risk of first generation side effects like sedation, anticholinergic effects, drug interaction, and patient is on polypharmacy. So, you need to give the right tablets. Comorbidities may influence the biologic eligibility, and workup is included to rule out malignancy or systemic disease. So, elderly urticaria is also where a specialist is required to give you the best possible treatment. Well, the good news is it does disappear. Urticaria is never with you for lifetime. It will disappear. Typically, 50% will disappear in 3 years. A severe disease will have lower early remission rate. Omalizumab treatment can have a positive effect on remission, and every 3 to 6 months, a treatment is changed by a doctor or they'll do step down therapy. But obviously, till 3 to 5 years, you need to go to a doctor, take treatment, and continue to follow it up as you expect a remission can happen with the newer and newer medicines, and most of these medicines our UK centers have a experience on using them, especially omalizumab biosimilars and the newer medicines. What's new? Well, there is a separate talk, but the dupilumab and remibrutinib are the two exciting molecules already being US FDA approved. Ligelizumab is discontinued, but we have tezepelumab, and more interesting is barzolvolimab, a KIT receptor blocker, which is being available. So next few 2 years, we may get newer and newer molecules to control urticaria. So all urticaria patients should not stop saying that it is not working. Definitely, there are better options available to give you a complete control of the disease. Patient rights and shared decision making is important. Your role is managing urticaria. Right to diagnosis, you must have a structured diagnosis from a dermatologist or a specialized center. UCARE centers are there available all over India, all over world. You can always go to these centers. Right to step up therapy, patients can have step up of antihistaminics and omalizumab. Quality of life assessment and right to regular review and right to information. Patients have the right that they should understand their disease and take the treatment as per advice of your consultant physician. Last 10 take key home messages for urticaria patients. CSU, you remember you are not alone. There is 1% of the population suffering. Urticaria is more than 6 weeks. You need to take a specialist care. You can track the activity with US Care. There's a cruise control app available all over the world. You can download and do your daily monitoring, your results, and a doctor find it very easy. We have second generation antihistamines which are very safe. First line treatment can be taken continuously. If they fail, we have got omalizumab and newer drugs also. Angioedema can be serious. Go to emergency medicine doctor. Food allergy is not a common cause of CSU, so avoid dietary or restriction. Assess your quality of life at every visit. Most patients achieve control and may achieve remission in 3 to 5 years, and seek UCARE certified centers for best guideline based standardized care. Well, thank you. These are key resources from UCARE website, Urticaria Network, and Gallon Network. And a UCARE certified centers are must be near you. You can go for them. Use your US app or Cruise app. Join patient support group and follow up of every 3 to 6 months with a specialist. And I'm sure your urticaria will find a good response and good treatment. Thank you very much for patient listening. I hand it over to the chair.
Dear Kiran, thanks a lot for this wide overview. I think it was a very nice summary. I'm sure our patients benefited a lot and they felt that they are not alone. So, science and the physicians are working for them. And now it's my pleasure to invite Dr. Laizan Wong from Taiwan. She will be speaking about what's new in chronic urticaria research and why it matters for patients. Now the stage is yours, Dr. Wong.
Thank you, Professor, for your kind introduction. And hello, everyone. I'm Dr. Huang Lisan, a dermatologist from Taiwan. Today, I'd like to talk about what's new in chronic spontaneous urticaria, not only from a scientific perspective, but also from what it actually means to you as a patient. Many patients feel the same things. It comes and goes, it improves, then suddenly there's again. And very often, no clear cause is found, and that can be very frustrating. Let's start with an important question. What is chronic spontaneous urticaria, or CSU? CSU means that hives, itchy skin rashes appear spontaneously without a clear triggers and keep coming back for more than 6 weeks. Sometimes there is also deeper swelling of the skin, which we call angioedema. CSU can last for quite a long time. In fact, about half of patients may have symptoms that continue for several years, sometimes even up to 5 years. In fact, it is not that there is no reason. It is that we are only now beginning to understand it better by many of the recent research. Before we talk about chronic spontaneous urticaria, let's first understand a key player in the skin, mast cells. Mast cells are a type of immune cells that live in our skin. They act like alarm cells in the body. When they are activated, they release chemicals such as histamine and inflammatory mediators, which can cause itching, redness, swelling, and hives. Another key player is something called the receptor on mast cells, which you can think of as an allergy switch on mast cell in the skin. Under normal conditions, this switch is only turned on when the body encounters a real allergen. Once activated, it signals the cell to release substances that cause itching and hives. However, in chronic spontaneous urticaria, the body is not reacting to something external like food or dust. Instead, it is reacting to itself. Think of it like a fire alarm going off without a real fire. Research shows that there are two main patterns in chronic spontaneous urticaria. Type 1 is allergy-like pattern. Patients with IgE-mediated autoimmune chronic spontaneous urticaria, also known as autoallergic urticaria, produces IgE antibodies to self-antigens. This means in some patients, the body behaves as if it has an allergy, even when there is no clear trigger. The symptom becomes overactive and can trigger the cells that cause hives. In other patients, the immune system mistakenly attacks the body's own receptors. Patients with IgG-mediated autoimmunity, also known as type 2B, have IgG autoantibodies, for example, against IgE receptor on mast cells. That means the body produces antibodies against its own receptors, which can directly activate the cells that cause hives, even without any external trigger. In addition to the types we just discussed, recent research suggests that some people may be naturally more prone to developing urticaria. One reason for this may involve a receptor on mast cells called MRGPRX2. You can think of this receptor as a kind of sensor on mast cells in the skin. When this sensor is activated, it can trigger the release of substances that lead to itching and hives. Recent research shows that in some people, this sensor is more easily activated due to genetic changes. So it is not because you did something wrong, it is related to your immune and genetic background. Another issue is that CSU does not affect everyone equally. It's more common in women than in men, and women tend to experience a higher symptom burden and a greater impact on their daily lives. Studies show that angioedema, a family history of CSU, and systemic symptoms are more common in females than in males. Quality of life impairment and sleep disturbance are also higher, and disease control is lower in females than in males. Meanwhile, treatment-resistant or refractory CSU is more common in women, especially after the age of 30. However, these differences becomes less noticeable as we get older and tends to fade after around age 65. This is not because women are more sensitive or weaker. Instead, it is related to biological differences, including how the immune system and hormones interact in the body. When you are diagnosed with chronic spontaneous urticaria, your doctor may sometimes check your other related condition, including autoimmune diseases, as part of a comprehensive evaluation. It is because studies found that approximately 10% to 28% of patients with chronic spontaneous urticaria have at least one autoimmune disease, and most of the autoimmune disease is diagnosed after urticaria. The most common comorbidity is Hashimoto's thyroiditis, seen in about 20% of patients, and it is associated with some clinical or overt hypothyroidism. When chronic spontaneous urticaria is associated with an autoimmune condition, it may sometimes be more active, last a bit longer, and take more time to respond to treatment. Beyond autoimmunity, many people think that chronic urticaria is just a skin disease, but actually it is more than that. Recent research shows that it can be connected to your overall metabolic health. Studies show that about 5 to 20% of patients with CSU may also have what we call metabolic syndrome. This includes conditions such as increased belly fat, high blood pressure, high blood sugar, and high cholesterol. This may be linked through low-grade inflammation and can happen in any endotypes. It is also associated with longer disease duration. Other studies also revealed that higher risk for cardiovascular disease in patients with CSU. Another area of recent research is microbiome. This refers to the microorganisms that naturally live on our skin and in our gut. These microbes are closely linked to our environment and may play an important role in disease. When the balance is disrupted, it can affect how the immune system behaves. Recent studies suggest that in some patients with chronic spontaneous urticaria, this balance may be altered. Dysbiosis may reduce short-chain fatty acid and increase lipopolysaccharide levels respectively, and facilitate mast cell-driven skin inflammation like CSU. And this could contribute to ongoing inflammation or increased sensitivity of the skin, and may also connect CSU to broader immune and metabolic pathways. Many patients notice that their urticaria worsens during stress. This is real. It is not just in your mind. There is a connection between the nervous system and the immune system. So stress does not cause the disease, but it can make it worse. When we are under stress for a long time, our nervous system becomes more active. Nerves in the skin start to release small chemical signals called neurotransmitters. These signals can directly talk to nearby mast cells, then mast cells release signals. These signals stimulate nerves again. This forms a loop that keeps the skin in an overactive state. In addition, studies have shown that stress can worsen CSU by disrupting the hypothalamic pituitary adrenal axis. Altogether, this creates a vicious cycle, where stress makes urticaria worse and worsening symptoms further increase stress. Another important discovery is that not all urticaria is the same. Different patients may have different underlying mechanisms. That is why some people respond quickly to treatment while others need more time. It does not mean your disease is worse, just different. Therefore, recent study using machine learning by analyzing data from many patients. Machine learning allows us to identify patient signatures, patterns in the data that reflect how the disease behaves in each person. These patterns help physicians group patients into different types based on how their disease works. And this means we can choose treatment more precisely in the future. So what does all this mean for you? Today, we understand that chronic spontaneous urticaria is not just a skin condition, it is part of a larger disease ecosystem in the body. Different factors such as the immune system, stress, metabolism, gut health, and even genetics can all interact and influence how your disease behaves. But most importantly, this new understanding brings good news. It means that we now have better, more targeted treatments. We are moving toward personalized care, and we are not only treating the skin, but the whole person. So if your urticaria feels unpredictable or difficult at times, please remember it is not random. It reflects a complex system that we are now beginning to understand and manage better. Thank you very much for listening.
Congratulations, Dr. Wong. This was a wonderful summary of what's happening under the skin, and also what can our patients change in their lives maybe. And yeah, I think after that, hearing that presentation, they can understand why urticaria is happening and why not answering to treatments so well. So thanks so much. And as I said, there will be discussion at the end. And now I think I should introduce myself, that I am going to talk about the emerging treatments in urticaria, new options and future perspectives for patients. I will also mention some parts Dr. Laizan already mentioned. Just give me a second. So now I am going to share my screen, and I will be talking about some similar things with Dr. Wong, because I will also talk why we need new treatments in urticaria and why our patients are not very happy with their treatments. And it's good news that we have new treatments. As Professor Kiran mentioned, we had antihistamines, we have omalizumab, but now we have new options like dupilumab and remibrutinib, which are now available in Europe and in US, and FDA and EMA approved medications. So we will be using them in the next years. So let's have a look why we need new treatment options for chronic urticaria. So first of all, disease burden. The disease is heterogeneous. Not all patients are the same, and we want good treatment. What does good treatment mean? We need treatment according to our patient's features and underlying mechanisms, and we want to change our disease progress. We want to control the disease fully, and also we want to put our patients into remission, to end the disease, to cure the disease. But now, currently, we cannot do this. And you see these amazing wheels, and also these angioedema in half of our patients are also suffering from these angioedema. But this is only the iceberg, the tip of the iceberg that we are seeing. Our patients are suffering a lot in their private life. They cannot go out with friends. They have to choose their diet. They are restricting themselves so much, even though we know that. And also Dr. Kiran also mentioned that there is not so much sense in restricting your diet so much, but sleepless nights, and they cannot really concentrate, focus on their work because of chronic urticaria and the unpredictability of these angioedema and wheals. So we understand you so well, I mean. And as Dr. Kiran mentioned, half of the patients still have this disease after 5 years. So it's a long-lasting disease. And if we don't treat our patients on time, then there will be a lot of consequences. Sleepless nights then will turn out to anxiety and stress and depression, and maybe they won't marry the person they love, or they will choose not to give a birth. So it's really very burdening for our patients. So, as Dr. Wang also asked, are all chronic urticaria patients the same? Yes. When the patients think that they are itching and they are having elevated wheals and some having angioedema, they think that it's all the same, or the physicians may think it's all the same. But the experienced physician knows that, and already mentioned by Dr. Wong, we know that they are different because not all of them are responding to antihistamines. Not all of them are responding to omalizumab. Not all of them are having angioedema. Some are having inducible urticaria. So they are all different. But why are they different? Because the basic pathophysiology of urticaria is that we have these allergy cells, which is called the mast cell, and mast cells are triggered, and then the histamine and many other mediators are released, and then we have the vessels vasodilated. I mean, they are dilated and widened, and some of the plasma is getting to the tissue, and then we are having these bumps in the skin. And what's different here is mainly some cells are coming to the wheels. For example, T cells, that's lymphocytes. For example, eosinophils, allergy cells, other allergy cells, and neutrophils and basophils are coming to this area of the wheels, and they are changing everything there, because that's why an allergic reaction is different than a acute urticaria or chronic urticaria, because of these cells that are coming to the wheel area. So it's not just mast cell, but we also have other cells, and they are continuing to trigger these mast cells. That's why some patients are responding to omalizumab, for example, because it's cutting the activation of mast cell, but some patients need combining it with cyclosporine, or some patients need immunosuppressive treatments to suppress the infiltration of these lymphocytes or other cells. And why antihistamines are not working in all of the patients? Because you see, there are a lot of cytokines and chemokines and other mediators released from mast cells. That's why in some patients, antihistamines are not working. So it seems basic, but it is not. Because what activates the mast cell is another story. As Dr. Wong mentioned, it is mainly an autoimmune disease, but you see this mast cell. This is the allergy cell, but you see there are a lot of receptors on the surface of these cells. And yes, the most important receptor is this high affinity IgE receptor. And usually this receptor is in normal life is responsible for allergic reactions. Urticaria seems like an allergic reaction, but it is not. We don't find that patients with urticaria have food allergy and that's why they are having urticaria and we take the nut from them. The urticaria is stopping. No, this is not happening in chronic urticaria patients, we know. But what's happening is they are usually not showing allergic reaction to exogenous allergens, but endogenous allergens. What does it mean? They are reacting to their own proteins. And these proteins then lead to the generation of autoantibodies that activate our mast cells. But this is not that easy. Sometimes complement cascade is involved. Sometimes coagulation cascade is involved. Sometimes neurogenic inflammation is involved because we know infections, stress, they are also triggering urticaria. And yes, maybe we should target other receptors in these patients. So you see, it seems a little bit really complex because yes, as a cause, we have the autoimmunity, but still half of the patients are not autoimmune. And having these autoantibodies is not enough. They also has to have some triggering factors, such as, all of our patients are saying, I had stress, I had infection, I had vaccination, and then my urticaria started. Yes, there should be other factors. For example, as Dr. Wong mentioned, there should be a genetic tendency and there should be something happening in their mast cells that because their triggering threshold is so low, they are angry mast cells in chronic spontaneous urticaria patients and they are looking for a reason to degranulate themselves and then we see urticaria. So some genetic factors, autoantibodies, and then the triggering factors are causing the wheals to appear. But then in some patients, then there is the chronicity of the urticaria, which is usually caused by the systemic inflammation or some other factors. For example, obesity, metabolic syndrome, increasing the duration of the disease and making it refractory to treatments, and also dysbiosis makes it make the disease more severe and also increases the duration. So they all have a role, and the recruiting cells also making it a vicious cycle because it's activating the mast cells again. So we need to target all of these to have a good response of urticaria treatment. That's why it's also important to have a healthy lifestyle. It's not only in the hands of the physician, but also in the hands of the patient, that they also have to have a healthy lifestyle. If they have obesity and metabolic syndrome, maybe they should start having more sport or having a balanced diet and try to lose some weight. And also healthy diet, also corrects the intestinal flora and may lead to decrease in the severity of the disease. So it's all we need to target a lot of pathways to take the full control. And there are phenotypes and endotypes, as it is mentioned. We have the type 1, which is the most common one, the autoallergic one. And the response to omalizumab is very good in these patients. But we also have the type 2B, who are very refractory patients, and they usually require immunosuppressives, and they show poor response to omalizumab treatment. But thankfully, these have a low prevalence, and not all urticaria patients are like this. Here you see a general definition of the endotypes of CSU. As Dr. Wong mentioned, type 1, type 2B, type allergic and autoallergic and autoimmune types, and we may have the mixed types, which are really also very refractory to treatment. And also there are patients, 40% of the patients do not have any autoantibodies, or maybe they have, but we are not there to detect these autoantibodies yet. So we are thinking that maybe they have a different pathway, underlying pathway in their disease, in their immune system. So here are some hypotheses. We can say complement coagulation pathway activated patients, type 2 inflammation activated patients, neuroimmune activated patients, and maybe some patients only have these mast cell signaling abnormalities that make their mast cells prone to degranulation or activation so much. And here we have the clinical endotypes of the disease, or phenotypes of the disease, which are making some patients refractory to treatment. When we have inducible urticaria together with chronic spontaneous urticaria, these patients are becoming refractory. When patients have angioedema, they are also more refractory. Female patients, more refractory. And when patients have systemic symptoms, which can also happen in 1/3 of CSU patients, these patients also are seen more refractory, and they have a higher disease activity. But thankfully, pediatric CSU is more easily manageable than adult CSU patients. In elderly patients, the severity is variable, but I would say they are usually more manageable. However, they have a lot of comorbidities, as Dr. Kiran mentioned. So also there are some biomarkers. We check if the patients have low total IgE. For example, if the total IgE is lower than 40, this can be a sign of a refractory disease. And patients with high CRP and high D-dimer can also be refractory patients, or may have a more severe disease. So there are also some biomarkers we use. So what do we have now currently? We have, of course, trigger avoidance. If you suspect a trigger, then please avoid it. And second, of course, pharmacological treatment, antihistamines. With antihistamines, we always need a higher dose of antihistamines. Standard doses only help 15% of the patients. And if we increase the dose up to 4 times, that means that we are receiving an antihistamine 2 times in the morning and 2 times in the evening, 2 tablets in the morning and 2 tablets in the evening. And this can lead to symptom relief in 35 to 50% of the patients. So it's also a good idea and very far from side effects, and it's a cheap treatment. So we love antihistamines, but still more than half of the patients require omalizumab treatment. This is an anti-IgE treatment, and patients receive it every month. It's an injection treatment, and this leads to treatment responses in 50 to 70%. It's really very effective treatment. And we have cyclosporine treatment, which has really a lot of side effects, so it's restricting its use, but it's also very effective treatment, I would say. That's why we still need new treatments in 15 to 30% of the patients. And you see here, there are a lot of new molecules coming up, and some failed clinical trials. For example, anti-IL-5, tezepelumab, they failed clinical trials. They won't be developed for CSU. You see here two molecules I made stars because they are now available in the latest guideline near omalizumab as a treatment option. That means that we will be using them very soon as options, and dupilumab is already being started using, and there are a lot of now experience on that. But remibrutinib is coming new, and this summer we will be prescribing remibrutinib hopefully to our refractory patients or some patients who don't want to use omalizumab treatment, or when omalizumab is not available. So it's an oral drug. And you see here, there are KIT monoclonal antibodies. KIT is the receptor that makes mast cells grow, proliferate. They give mast cells life. And when we block KIT, then mast cells die. And when there is no mast cell, then there is mainly no CSU. And you see other options here. Mainly we have the MRGPRX2 receptor antagonists, which is really gaining a lot of attention, as Dr. Wong already mentioned. They are in clinical trials, and JAK inhibitors seem to be promising agents in use for CSU. And yes, I will be speaking very briefly about these molecules, but not all of them. Mainly dupilumab. Dupilumab is a monoclonal antibody which is targeting IL-4 and also IL-13. And what's it doing in CSU? It's reducing mast cell activation, mainly decreasing IgE production and blocking this allergic inflammation, and also decreasing itch really very powerfully in CSU patients. And it's now approved by FDA and EMA in CSU, and it's an injection therapy every 2 weeks. And you see the clinical trial results. So it leads to well-controlled urticaria in 43% of the patients. So it's an effective treatment. The effectivity starts at week 3, and after stopping the treatment, it shows a long-lasting remission in some of the patients. So it's the positive side of this treatment. And side effect profile is very good, so it's a safe treatment, I would say. Remibrutinib is the other one, which is a BTK inhibitor. What is BTK? As you see in this picture, mast cells, basophils, B cells, and many other cells have BTK in themselves, and it is a signaling molecule that without these signaling molecules, cells cannot work. So that means that when in these high affinity receptor, IgE receptor, when there is a signal came, this signal should be transduced to downstream so that the degranulation happens in the cell. But when BTK is blocked, then this degranulation is not happening. So mast cells are not working, degranulating, basophils are not degranulating, and also B cells are not working, which that means that they are not producing these autoantibodies that are coming and activating our mast cells in CSU patients. So it has a dual action in patients with CSU, so it can help mainly both for type 1 and type 2B autoallergic CSU patients. So I am moving a little bit quicker now because, and it's also, remibrutinib is also approved by FDA and EMA in CSU, and it's an oral treatment, and it's taking 2 tablets daily, 1 in the morning, 1 in the evening. So here is the study design, and there is 52 weeks result and the effectivity starts at week 1. And yes. And you see, after 52 weeks, well-controlled urticaria rates were over 60%. So it's a nice treatment. It's a safe treatment, and it was mainly very well tolerated by the patients. Barzolvolimab is cutting the connection between the stem cell factor, which is the food for mast cells, with the receptors, KIT receptors on mast cells, so that mast cells are dying and not growing. It's a really very effective injectable treatment. It's given usually 2 to 3 months apart, because its effectivity lasts 2 to 3 months because the mast cells are not working and they are not proliferating anymore. So barzolvolimab really shows a very good response. At 52 weeks, you see complete control, 71%. So when looking forward, this is already being shown. What we need and what's important for our patient, we want to see how in real life dupilumab and remibrutinib will work and which patients need these treatments. So we need these real life data, and also we want the clinical trial results, for example, from these MRGPRX2 antagonists and maybe the JAK inhibitors. So we are also waiting for briquilimab and barzolvolimab clinical phase 3 clinical trials. But the most important is we want to have a precision medicine. Which patient needs which treatment? We want to understand that, and we want to put ourselves into remission. We want to cure our patients, and this was the wish of Marcus Maurer. This is his last, one of the last publications, and he defined that we need to target disease modification and remission in chronic spontaneous urticaria patients, but we are never giving up and following Marcus Maurer. So this is all from me, and now I think I will check if there are any questions on the chat. Dear Kiran, do you see any questions?
Yeah, there are many questions. I'll just tell you how to treat CSU plus urticaria vasculitis. This is being asked by a patient. So if you can try to answer that, how do you
Yes.
treat from Diana Diaz?
Okay, so urticarial vasculitis is a different entity. It's a vasculitis. It's not urticaria, but in very rare patients they can be together. And when this is the case, I would prefer treating with hydroxychloroquine or colchicine, or omalizumab also works in many of normal complement and urticarial vasculitis patients, and also cyclosporine can work in urticaria vasculitis patients. But we need to take them differently because they may have other associations, these patients.
Yeah, there is one more question which I'll take. Role of IL-31 in CSU. So interleukin-31 is a key cytokine involved in chronic skin inflammation and pruritus, with significantly elevated levels are found in CSU patients. Each producing, basically it is used for each producing IL-31. So it has a role in CSU, but as on today, there is no update or trials which are seen on the website, but it could be used in any itchy conditions, that is CSU. Emek, you have anything on IL-31 new? Somebody, Nelson Rosari is asking.
I didn't hear any clinical trials on that, but I think alone I don't think that it can be helpful in alone in CSU patients. Maybe in combination. Maybe if the itch doesn't resolve with omalizumab, dupilumab, or remibrutinib, we can combine it with IL-31. But I don't think it will work alone. But
Yeah,
maybe we can.
right.
It's open. to clinical trials, of course, because it's a safe treatment also. We know that. Okay.
That's all.
Yes,
There are no more
this
questions.
question was from Nelson Rosario. Hi, Nelson. Thanks for listening to us. And there was a patient from our physician from Kırıkkale, Turkey. So thanks for your questions. And other questions, do you see?
No, I don't see any more questions.
Okay, so I should open the outro and we should say goodbye with this presentation. So I am sharing this. Sorry. And then we are coming to the end of this nice webinar. I hope you learned a lot and you enjoyed it. Please keep watching UCARE for You webinars, because UCARE for You is targeting our patients, and it's updated and it's an expert knowledge channel, so you can trust these information 100%. It's not the information coming from which source you don't know. It's very important, and it's a very good channel. And please took the survey and answer the questions. Did you like this webinar or not? We want to hear from you. And this is a patient advocacy organization, VCU. This VCU is the patient advocacy organization from US. You can also follow their social media channels, and please subscribe to a newsletter of Global Allergy Network, so that you don't miss any of our activities, and stay connected. Follow us on social media and websites. And thanks for the sponsors for sponsoring us, so that we can provide good knowledge to our patient and also physician friends. And thanks to Professor Dr. Kiran Gotse and Dr. Laizan Wong from Taiwan for their wonderful presentations. Hope you enjoyed it. And to next time, I think the next webinar will be on the 26th of May. And please follow us and don't miss it. Bye-bye.
Bye bye. Thank you. See you.
Bye. Thank you.